Hello, everyone. Today, Rehab Podcast Weekly presents Episode 4 Frozen Shoulder Assessment and Interventions.
Ever had that moment where a simple movement, like reaching for something on a shelf or even just putting on a jacket, suddenly becomes a painful struggle? That nagging ache in your shoulder that just tightens and tightens, limiting what you can do day in and day out.
Yeah.
That's the kind of frustrating scenario we're diving into today.
Yeah.
Frozen shoulder, or as it's known in the medical world, adhesive capsulitis.
Exactly. And for this deep dive, we're putting on our rehab hats, looking at the evidence through the lens of physical therapy.
Right.
Our goal is to understand not just how frozen shoulder is identified, but maybe more importantly, what we as movement specialists can actually do to help you get back to using your arm without that pain and stiffness.
So we've gathered quite a bit of information to unpack here. We're looking at medical reviews that give us the clinical big picture, a Wikipedia entry for a solid foundation,
Yep, the basics.
exercise guides that show potential recovery strategies, and even insights from a survey of fellow health professionals about what's happening in practice. We're pulling all these threads together to give you a clear, practical understanding.
Okay, let's unpack this, starting with the basics. Imagine the shoulder joint. That's where your arm bone meets your shoulder blade. It's surrounded by a capsule, a kind of flexible sac.
Okay.
With frozen shoulder, this capsule thickens and becomes stiff. One of our sources even calls it contracture of the shoulder, which really paints a picture of that tightening feeling.
Yeah, that sounds descriptive.
And it's not just thick. It can also develop adhesions, where it almost sticks to the ball of your arm bone, the humerus.
Okay.
This combination of stiffness and sticking leads to that characteristic pain and severely restricted movement.
It's more than just a bit of stiffness, though, right? It sounds like from a therapy perspective, we need to be aware that this isn't always an isolated issue just in the shoulder.
Absolutely. That's crucial. While the main problem is in the shoulder joint itself, we always need to consider what else might be going on.
Like comorbidities.
Exactly. The medical literature really emphasizes looking for and addressing any other conditions that could be contributing or coexisting with the frozen shoulder. Think about things like diabetes, rotator cuff problems, bursitis, inflammation of those fluid-filled sacs, and even issues arising after shoulder surgery. It's often part of a bigger picture.
Okay, so if someone walks into the clinic with that persistent shoulder pain and stiffness, how do we, as movement specialists, start to figure out if it's truly frozen shoulder and not something else causing similar symptoms? Let's talk about our diagnostic process.
Well, one of the first things we consider is the difference between primary and secondary frozen shoulder.
Why?
Primary or idiopathic means it came on without a clear, identifiable trigger, just sort of appeared.
Right.
Secondary means it developed because of another underlying condition or event, like surgery or an injury or maybe diabetes. Interestingly, some of the more recent research suggests that primary frozen shoulder might actually be less common than we previously thought.
That's interesting. And who tends to be more susceptible to developing this? Are there specific risk factors that stand out from a rehab perspective?
Definitely. Age is a big one. We see it most frequently between the ages of 40 and 70.
Okay, middle age.
Yeah. Also, it tends to affect more women than men. The connection with diabetes is also really significant for both those who use insulin and those who don't, as well as individuals with prediabetes.
Right.
In fact, the incidence can be as high as 20% in people with diabetes, which is something we always keep in mind.
Wow, 1 in 5. That's a really strong link. What else should we be aware of when it comes to risk?
Well, a history of frozen shoulder on one side increases the likelihood of it developing in the opposite shoulder.
Oh, great. Bilateral possibility.
Yeah, unfortunately. Recurrence in the same shoulder is also possible, especially, again, in our patients with diabetes.
Okay.
One study we looked at mentioned some other associations, although maybe the evidence isn't quite as strong. These included things like knee problems, constipation, poor sleep quality.
Sleep makes sense with the pain.
Definitely. Also, thyroid issues, problems with cholesterol and other fats in the blood, Dupuytren's contracture, that hand condition autoimmune diseases, and even certain surgeries like when lymph nodes are removed from the armpit, axillary dissection.
That's quite a list of potential links.
Ah.
But are there things we might assume are related that actually aren't, based on the research? Things that don't seem to increase risk?
Yes. That same study looked at a whole host of factors that didn't show a significant connection. Things like your job, where you're from, marital status, the time of year the pain started, how long you'd had the issue, what you thought caused it, a general history of surgery, high blood pressure, respiratory problems, high cholesterol, heart conditions, neck or lower back issues like cervical spondylosis or lumbar disc herniation, rheumatoid arthritis, gout, smoking, and alcohol consumption.
So a lot of common things that don't necessarily point towards frozen shoulder risk.
Exactly. So while someone might have some of these things, they don't automatically mean they're more likely to get frozen shoulder.
Okay, so knowing who might be at risk gives us some clues. But as movement specialists, what do we actually observe and feel when we examine someone with suspected frozen shoulder? What are those key physical signs we look for?
Yeah, the physical exam is really the cornerstone of diagnosis. We start by simply observing the patient. Are there any signs of muscle wasting around the shoulder? Atrophy? Any scars that might suggest previous surgery that could be a factor?
Right.
When we palpate or feel the shoulder, patients will often report general pain, but there aren't usually specific pinpoint tender spots like you might find with, say, a rotator cuff tear.
Okay, more diffuse pain.
Exactly. And then comes the crucial part, assessing how the shoulder moves, right?
Range of motion.
Yes, range of motion or ROM, that's a key indicator.
Yep.
We'll check both active ROM, what the patient can move on their own, and passive ROM, how far we can gently move their arm for them.
And the difference there is important.
Very. With frozen shoulder, we see a significant restriction in both active and passive ROM, particularly in abduction, lifting the arm out to the side, and external rotation, rotating the arm outwards. That loss of passive range of motion is a really important sign. It helps us differentiate frozen shoulder from other shoulder problems, like a rotator cuff tear, where passive range might be less limited, maybe even normal if it's just pain-limiting active movement.
Got it. So the joint itself is stuck, essentially.
Pretty much. Interestingly, internal rotation or reaching behind your back often shows the most significant restriction and tends to be the last movement to fully recover.
Reaching the back pocket or bra strap.
Exactly, those movements.
Okay, so limited movement in those key directions, both active and passive. What else might we notice during our assessment?
Well, rotator cuff strength is generally normal, surprisingly, within the available range of motion they have.
So the muscles can work, they just can't move far.
Correct. We might also observe what we call a shrug sign, where the patient compensates for the limited shoulder joint movement by excessively elevating their entire shoulder blade when trying to lift their arm, especially trying to get it up to 90 degrees.
Yeah, you see that hike.
When we assess the feel of the joint itself, specifically the glide, how the head of the humerus moves within the socket, we often find it significantly reduced, particularly the downward movement or inferior glide.
Okay, that makes sense with the limited abduction.
It does. And while a neurological exam is usually normal, it's important to perform one just to rule out any nerve involvement from the neck, especially if the patient reports pain radiating down the arm or any specific weakness.
Always good to rule out the neck. So we're looking at these objective physical signs, but what about how this actually impacts someone's day-to-day life? What kind of functional limitations do our patients typically describe?
Oh, these limitations can be really disruptive. Sleep is often a huge issue because of the pain. It's difficult to find a comfortable position, especially lying on the affected side.
I hear that all the time.
Yeah, and simple daily tasks become a challenge. Things like getting dressed, reaching into a back pocket for a wallet, or even just brushing or styling their hair, reaching overhead.
Forget about it.
Exactly. This can then have a knock-on effect on their work and leisure activities, especially anything that involves overhead tasks or participating in sports that require a full range of shoulder movement.
It sounds like it can significantly impact their independence and overall well-being. And are there any specific lab tests or imaging that we as rehab professionals should be aware of in the diagnostic process, even if we don't order them ourselves?
Yeah, from our perspective, understanding that potential role of underlying conditions like diabetes is key. So we might suggest the patient discuss with their GP whether a fasting glucose test is appropriate if they haven't already been screened.
Good point.
While certain inflammatory markers in blood tests like ESR-CRP might be elevated in some cases of primary frozen shoulder, they're not very specific, so not hugely helpful for us in making the diagnosis. Regarding imaging, while we don't typically order it, it's good to know that an MRI can show characteristic signs of adhesive capsulitis, like capsular thickening. Ultrasound findings are also documented in the medical literature, but often, really, the diagnosis is made primarily based on our clinical examination, the history, and the physical findings.
That hands-on assessment is key. All right, so we have a solid understanding of how we identify frozen shoulder. Now let's move on to the strategies we use to help our patients recover. What are the main intervention approaches from a physical therapy standpoint?
Okay, intervention. Well, non-surgical management is almost always the first line of treatment we employ.
Makes sense. Start conservative.
Yeah.
And within non-surgical management, exercise and hands-on therapy are central, right?
Absolutely. Exercise and physical therapy are the cornerstones of our approach. And interestingly, the research strongly suggests that supervised exercise programs, where we can guide and adjust techniques,
Yeah.
are more effective than simply providing a list of exercises to do at home unsupervised.
So that guidance makes a difference.
It seems to. Certain techniques have also demonstrated more benefit than others in the research. For example, posterior glenohumeral joint mobilizations, specific manual techniques to improve the movement at the back of the shoulder joint.
Okay.
Mirror therapy, targeted rotator cuff strengthening, techniques like spray and stretch for pain relief, and mobilizations performed at the very end of the available range of motion all have moderate evidence supporting their use.
Moderate evidence, so reasonably good confidence they help. What about some of the other techniques we might have learned or heard about? Do they hold up?
Well, some techniques show smaller effects. Things like continuous passive motion machines, exercises specifically aimed at improving awareness of shoulder blade movement, general shoulder blade exercises, scapulothoracic exercises, and even some traditional forms of exercise like Yi-Jin-Jin.
Smaller effects, okay.
And then there are techniques that haven't shown significant benefit compared to control groups in some studies. This includes things like electromagnetic therapy, certain types of joint mobilization called Colton-Born mobilization, and instrument-assisted soft tissue mobilization like Graston.
So not everything commonly used has strong backing.
Right. It really highlights the importance of staying up to date with the evidence to guide our treatment choices effectively.
It sounds like we need to be really targeted in our therapy approach. And the sources we looked at emphasize the importance of addressing both the shoulder blade, the scapulothoracic area, and the main shoulder joint muscles, the glenohumeral ones. Why is that combined approach so crucial?
Think of it like building a stable foundation for a house. The muscles that control your shoulder blade, like the serratus anterior, trapezius, and rhomboids, provide that stable base for your arm to move efficiently and properly.
Okay, the platform.
Exactly. Strengthening these helps with proper alignment and reduces unnecessary stress on the shoulder joint itself. Then, of course, we also need to directly address the muscles that control the movement and stability of the main shoulder joint, the rotator cuff muscles. Subscapularis, infraspinatus, teres minor, supraspinatus.
Got it.
A coordinated effort between these two muscle groups is essential for restoring full, pain-free function. You need both scapular stability and glenohumeral mobility and control.
That makes perfect sense. Stability and mobility working together. And for someone listening who's currently dealing with a frozen shoulder, what are some examples of those home exercises that a physical therapist might recommend as part of a supervised program?
Yeah, some common ones include pendulum exercises where you lean forward and let the arm hang, gently swinging it in small circles in both directions. Helps with pain and some gentle motion. Passive external rotation, where you use your unaffected arm to gently help stretch the affected arm outwards, maybe holding a stick or cane. Wall walks or slides, where you use your fingers to walk your arm up a wall, either forwards or sideways. The classic crossbody shoulder stretch, gently pulling your elbow across your chest towards the opposite shoulder. The towel stretch, using a towel draped over your good shoulder to help pull the affected arm up your back for internal rotation. Chest stretches performed in a doorway to open things up.
Right.
An inferior capsule stretch, which you can do while seated by leaning your body away from the affected arm while it rests on a table. The sleeper stretch, performed lying on your affected side and using the other arm to push into internal rotation. Gotta be careful with that one not to pinch.
Yeah, needs good instruction.
Definitely. And even isometric exercises, where you push against a wall or another stable object with your arm in different positions, flexion, extension, abduction, rotations, without actually moving the joint much, just activating the muscles.
So a good variety of movements aimed at different aspects of shoulder mobility and stability.
Yeah.
And are there general guidelines we give patients on how to perform these at home, like how long to hold stretches or how many repetitions?
Yeah, well, the specific prescription always depends on the individual and their stage. The general advice is usually to hold each stretch for around, say, 20-30 seconds, not bouncing.
Sustained hold.
Exactly, and to repeat them several times, maybe multiple times throughout the day, if possible. But the key is always listening to your body. Avoid pushing into sharp, intense pain. The goal is a gentle, sustained stretch sensation, not agony.
pain-free range or just into mild discomfort?
That's the idea. We also came across the mention of PNF techniques in the research. What are those, and how do we utilize them in the rehab setting for frozen shoulder?
PNF. Proprioceptive neuromuscular facilitation. A bit of a mouthful, but basically involves integrating specific muscle contractions, like pushing or pulling against resistance with stretching techniques.
And the evidence suggests that PNF can be particularly effective in decreasing pain and improving range of motion in frozen shoulder, maybe even more so than just passive stretching alone in some cases.
How did that work?
Well, one specific movement pattern often used is the D2 flexion pattern. Think about it like drawing a sword from your opposite hip up across your body and reaching up and out, finishing with your palm turned upwards.
Okay, that diagonal motion.
Exactly. We can provide resistance during parts of that movement and then follow it with a stretch in the opposite direction. It helps improve both strength and flexibility in a coordinated, functional way.
Interesting. So exercise and manual therapy are key components of our rehab approach. What about medications like corticosteroid injections? How do they fit into the overall picture from a physical therapy perspective?
Yeah, corticosteroid injections can play a really valuable role, especially in the earlier, more painful stages of frozen shoulder, what we sometimes call the freezing stage.
When pain is dominant.
Exactly. By reducing inflammation within the joint capsule, they can help to significantly alleviate pain. And that pain relief makes it much easier for patients to actually engage in the exercises and stretches that we need them to do to restore their movement.
So it can open a window for therapy to be more effective.
Precisely. The injection is often administered directly into the glenohumeral joint itself.
And our survey of health professionals gave us some insights into how these injections are currently being used in practice, right? What did that show?
It did. There was a pretty strong consensus among the healthcare professionals surveyed, PTs, doctors, etc., about the usefulness of corticosteroid injections, particularly when given during that initial pain-dominant phase.
Okay, agreement there.
The glenohumeral joint was the preferred site for the injection rather than, say, the subacromial space alone. And triamcinolone was a commonly favored corticosteroid, often at a dosage of 40 mg/ml.
Specific steroid and dose preference.
Seemed to be, yeah. And lidocaine, or a similar local anesthetic, was frequently used along with the steroid to help with immediate pain relief right after the injection.
Interesting to see that level of agreement in practice. But we also noted some discussion or maybe debate in the research about the best way to administer these injections, didn't we?
Yes, absolutely. There's an ongoing debate about whether injecting just the glenohumeral joint is sufficient, or if combining that with an injection into the subacromial space, the area beneath the acromion, that bony roof of the shoulder offers additional benefits.
What's the thinking there?
Well, some studies have suggested a slight improvement in internal rotation with the combined approach. However, others indicate that injections into the glenohumeral joint alone might provide longer-term pain relief. So the jury's still out a bit, and the optimal approach might vary from patient to patient.
Right, needs more research maybe. And the choice of steroid and the use of local anesthetic also have some nuances that we should be aware of as part of the broader treatment team.
Exactly. While different corticosteroids like triamcinolone and methylprednisolone are generally considered to be similarly effective, some evidence suggests triamcinolone might offer a slightly longer window of therapeutic benefit for some individuals.
Okay.
And regarding the local anesthetic, most practitioners do favor using lidocaine for that immediate pain relief. However, some might choose to omit it, maybe due to potential systemic effects, although unlikely with typical doses, or perhaps in settings with limited medical support immediately available. There have also been some concerns raised in the medical literature about the potential negative effects of repeated local anesthetic injections on tendon health, but again, probably less of an issue with the typical 1 or 2 injections used for frozen shoulder.
Good to know the context. What about hydrodilatation? We saw that mentioned as another type of injection therapy. How does that differ?
Right, hydrodilatation or hydrodistension. This involves injecting a much larger volume of fluid, typically sterile saline, along with a corticosteroid and a local anesthetic into the joint capsule.
By a large volume.
The idea is to try and physically stretch the tight, contracted capsule from the inside out, essentially distending it.
Ah, like inflating a stiff balloon.
Kind of, yeah. While the hard evidence isn't overwhelmingly in favor of hydrodilatation being significantly better than standard corticosteroid injections across the board,
Okay.
some practitioners do report positive outcomes with it. And a Delphi consensus among experts actually encouraged its use, especially when performed with imaging guidance like ultrasound using isotonic saline. So it's still an option considered by many.
And oral steroids, briefly mentioned.
Yeah, oral steroids might offer some short-term pain relief as well, but they have more systemic side effects and don't target the joint directly in the same way that injections do, usually reserved for specific situations or short courses.
Okay, so we've discussed our primary approaches as physical therapists, exercise, manual therapy, and understanding the role of injections. What happens when these conservative measures just don't provide enough relief? Is surgery ever a consideration that we might discuss with the patient and their doctor?
Yes, absolutely. Surgery is an option for those with persistent and severe frozen shoulder who haven't responded adequately to a good course of non-surgical treatment, usually several months at least.
And what does surgery typically involve?
The most common surgical procedure nowadays is an arthroscopic capsular release. This is a minimally invasive technique.
Keyhole surgery.
Exactly. A surgeon uses small incisions and specialized instruments, including a camera, to go into the shoulder joint and carefully cut or release the thickened and contracted parts of the joint capsule. This helps to immediately restore range of motion.
And because it's minimally invasive.
The recovery time tends to be faster compared to older traditional open surgery methods, less tissue disruption.
What does the rehabilitation process look like after someone has undergone a surgical release? Is PT still important?
Oh, post-operative rehabilitation is absolutely critical. You could argue it's just as important as the surgery itself.
Why is that?
Because the goal is to maintain the range of motion gained during surgery and prevent the shoulder from stiffening up again, which it will try to do. So we typically start with gentle, passive, and active assisted range of motion exercises very soon after surgery, sometimes even the same day or the next day.
Get it moving quickly.
Yes. And then we gradually progress to more active exercises and strengthening as the shoulder heals and the patient tolerates more activity. It's quite an intensive process initially.
And is arthroscopic release the only surgical option we might encounter patients having had?
Manipulation under anesthesia, or MUA, is another surgical technique. It's less common now, perhaps. Here, the patient is put under general anesthesia,
Okay.
and the surgeon gently but firmly moves the shoulder through its full available range of motion to physically break up the adhesions and scar tissue in the joint capsule.
So no cutting, just moving it forcefully.
Essentially, yes. However, a systematic review we looked at compared MUA to arthroscopic release and actually didn't find a clear advantage of one over the other in terms of either final range of motion or how patients reported their outcomes. Arthroscopic release might allow for a more controlled release, though.
Interesting. So similar outcomes reported. And this has been a really comprehensive look at interventions.
Yeah.
But there was one more aspect that caught my eye in the sources. The idea of watchful waiting. What's that about?
Yes, that was an interesting study. It compared an initial period of watchful waiting, basically monitoring the condition without starting formal PT right away, to beginning physical therapy immediately.
And what did they find?
What they found was that while both groups did improve over time, supporting the idea that frozen shoulder can be self-limiting,
Right.
the group that started physical therapy right away incurred significantly higher healthcare costs without showing a substantial added benefit in terms of patient-reported outcomes compared to those who initially just waited.
Wow. So PT cost more, but didn't necessarily lead to feeling much better faster in that study.
In that particular study, yes. It certainly brings up some important considerations about the timing and maybe the necessity of early intensive intervention for everyone with this condition versus perhaps a more tailored approach.
It definitely does raise some interesting questions about the most effective and perhaps most cost-effective initial approach for some individuals. So, as we start to wrap things up, what are the key messages that we, as physical therapy professionals, want to leave our listeners with regarding frozen shoulder?
Okay, key takeaways. From a diagnosis perspective, remember it's often a complex condition, potentially multifactorial, but a thorough hands-on clinical examination by someone experienced is paramount. We also need to be really mindful of associated conditions, particularly diabetes, given that strong link. When it comes to intervention, there's a spectrum of non-surgical options we utilize. Supervised exercise programs incorporating specific manual therapy techniques seem to show the most promise based on current evidence. Corticosteroid injections can be a very valuable tool for pain management, especially in those early painful stages, potentially facilitating more effective therapy.
Good point.
Surgery, like arthroscopic release, remains a viable option for those who don't respond to conservative care. And in all cases, whether post-injection or post-surgery, or even with just conservative care, ongoing rehabilitation and sticking with the program is essential for a successful outcome.
And it sounds like despite all the research, there's still a degree of uncertainty surrounding this condition. One of our sources even described the experience for patients as living with uncertainty, and the understanding of the condition itself as being in a bit of a no man's land.
That phrasing really resonates, doesn't it? It highlights the ongoing challenges in fully understanding the exact mechanisms. Why does that capsule thicken and stick? And therefore, in determining the optimal treatment pathway for every single person, it can be frustrating for both patients and clinicians.
Yeah, that uncertainty is tough.
However, research continues to evolve. For instance, there's an ongoing clinical trial we read about that's exploring a molecular therapy, interestingly, one initially developed for eye disease, as a potential new treatment for frozen shoulder.
How'd that work?
Well, this approach targets the formation of new blood vessels, neoangiogenesis, and a specific pain signaling molecule called substance P, both thought to be involved in the inflammatory and painful process of frozen shoulder. The hope is to reduce the duration and severity of the condition, particularly for women who we know are more frequently affected. So this kind of research offers exciting possibilities for future, maybe more targeted treatment approaches.
That's really interesting to hear about these potential new avenues on the horizon. So given that frozen shoulder can often resolve on its own over a long period in many cases, yet we have this range of interventions with their own potential benefits, costs, and time commitments. Here's a final thought for you listening. What might be the most empowering first step for someone experiencing these frustrating symptoms?
That's a great question to ponder.
Perhaps it's having that detailed conversation with a knowledgeable healthcare professional, like a physical therapist or their doctor, really getting a clear diagnosis, understanding your specific situation, discussing the pros and cons of the different options, including watchful waiting, injections, therapy, surgery, and allowing you to be an active participant in deciding on your own recovery journey.
Absolutely. Shared decision-making is key.
Thanks for exploring this deep dive into frozen shoulder with us today.
Edited by Min.Rehab. Thank you all for listening, and see you in the next podcast.